Good morning, everybody, and welcome to Health Talk. I am your host, Dr. Neeru Prasad, pediatrics and emergency medicine physician affiliated with Henry Ford Health System, St. Joe, Oakland, and Beaumont. The theme of our health talk today is treatment with immune therapies in cancer. Joining us today as our guest speaker is Dr. Mohammad Muhsin Chisti, who is assistant professor at McLaurin and Karmano Institute. And he is going to highlight our viewers of some of the new modalities for the treatment of the cancer with immune therapies. Good morning and welcome to my show, Muhsin.
Good morning, everybody. It's a great pleasure for me to come to this show and talk about recent advances in cancer immune therapy.
So this is the second segment. For those of viewers who have not seen, we advise them to see the first segment of your show also.
Right, that was more targeted therapy in cancer, right?
Target therapies in cancer. So before we get started, can you give your introduction to our viewers, please?
Yeah, as mentioned, my name is Mohammad Muhsin Chisti. I'm an oncologist, a hematologist, and I work in various hospitals, including McLaurin, Oakland, and I'm affiliated with Karmanos Cancer Institute.
Oh, so that's good. So tell us, what is cancer immune therapy?
So as we mentioned in our previous segment, like cancer is a clone. It's when the cells go crazy, they start multiplying. So what we found historically is there is a strong relationship of cancer with immune system. So there are a lot of cancers that we have found are related to immune suppression or hyperimmunity. So we found that people that get transplant, they are put on immune suppressants. So down the road, they have a very high chance of developing cancers like lymphomas. Similarly, people that have immune compromise, like there are people that have genetically compromised immune systems, they also develop certain types of cancers.
Those with the herpes, zoster, and other.
Correct. So since their immune systems are not the strongest, they kind of tend to develop cancers as well. The strongest evidence we have is in lymphomas. We have seen this in kidney cancers and a lot of other cancers as well.
So this is very important to know that immunocompromised people are more susceptible to develop some kind of malignancy, whether it is prostate, kidney, or could be any place. Right. Yes. So then the types of cancer immune therapy.
So talking about the various types of immune therapy. So immune therapies, as we mentioned, are based on the response of the person to the immune therapy, to the cancer. So we have various types. One of the types that we first talk about are non-specific immune therapies. These are classical cytokines that we have used for many years for different types of cancers. Then there are more targeted immune therapies. Then there are immune checkpoint inhibitors. Then there are monoclonal antibodies that we use. Then there are vaccines. Then TIL therapy, then CART, C-A-R-T, that we'll talk about later.
Right, yeah.
So that's kind of the broad classification. The whole point is basically what we are doing is we are exploiting our own immune system for the benefit of conquering cancer. We know once there's a cancer in the body, the nature has made us such that we can have an immune response and we can fight the cancer. But what happens is there are feedback mechanisms that prevent these cells from killing the cancer cells. So that's what we exploit. That's what we explore for the benefit of cancer therapy.
Right, especially for something like a lymphoma, and I think this thing is working, isn't it? Immune therapies certain cancers
Right.
it
I
is
think
working.
I think where we are right now, I would compare this to the era of Alexander Fleming, like when he discovered the antibiotics, the penicillin,
Yeah,
that
yeah.
revolutionized the
Penicillin,
whole
right. It
era
changed the
of
whole world.
infections. Exactly. I think we are kind of primitive in cancer technology yet. We are advancing, but I compare this age to that particular age. If for penicillin, Great Plague of London would not have happened. Similarly, we are kind of going
Yeah.
there, and we are trying to figure out those vaccines for cancer as well.
Right, yeah, because
Yeah.
people are tired of getting those medications.
Right.
Those medications are so cytotoxic.
Correct.
This is something new, so they will rather go for. I'm sure you must have noticed in your practice also.
Correct. So chemotherapy has been there for 20, 30, 40, 50
Right.
years, but you're
Now-
right. They stop working. Either the cancer patient is not able to tolerate, or they stop working,
They
and then you don't
stop.
have options. But now you're coming to an era where
Yeah.
you have something different to give to the patient, where his own body is trying to fight cancer.
Fight the cancer, which is,
Right.
yeah. So, what are the monoclonal antibodies?
So before going to
for the-
monoclonal antibodies, I'll talk
you want
about
to talk,
cytokines.
talk about cytokine. Yesterday I was in the library, such a long time. I read this, but I just could not.
Yeah, since the concept is kind
Yeah,
of new, it's evolving,
yeah,
it's ever changing.
cytokines, yeah.
So the
Role
reason I
of
want to
cytokines, how they work. Like.
Right. So the reason I want to talk about cytokines first is because
Cytokines.
they are the ones that have been used for many years, and those are the agents that paved the way for immune therapy in cancer.
Okay.
So cytokines are actually agents that act in the signaling pathway in our body. They are secreted by the immune cells, and they lead to the immune response. So they are released in any infection. They are released in any inflammation. So what we have done is, since we know there are cancers like kidney cancers,
So,
melanomas.
excuse me, cytokines, are they from the lymphocytes? Or
Correct. So they are produced from the immune
From
cells,
the immune
lymphocytes,
lymphocytes.
macrophages, and all those cells. So what we have seen that since there are immune cancers like kidney cancers, melanomas, lymphomas, hairy cell leukemias, when we induce a cytokine response in those patients, they tend to have an excellent response and cancers going into remission. I'll give an example. For instance, I had a patient who had stage 4 kidney cancer.
Yeah.
So there, in the therapies that we offer to them, there is a targeted therapy, there are other therapies, but one of the therapies that we offer them is interleukin-2, which is a cytokine, which is an immune modulator.
Cytokines.
Yeah.
Okay.
So we told the patient, there's a 10% chance that you might go into remission, but you're in good shape, you're in good health. This might be something worth trying. And we admitted the patient in the ICU, gave this interleukin-2 as appropriately as is mentioned in the protocols. And guess what? She had an excellent response, and she continues to be in remission. But
Great.
that's like 10% of the cases,
Yeah.
but they do work.
But at least, it is worth trying.
Exactly.
Yeah.
Similarly, then you have, interferon alpha. Interferon alpha is not only used in cancers, it's also used in other infectious diseases. It has
Yeah.
been used in hepatitis C,
Yeah, hepatitis C and
Right.
interferon. Big write-ups in the literatures about this.
Right. So that paved the way for the immune therapy in cancer.
Right.
Then subsequently there came monoclonal antibodies. Then we talked about targeted therapies, like different types of monoclonal antibodies that have been successfully used so far. Now, in last few years, what we have seen is new thing that's known as immune checkpoint.
Immune checkpoint.
Right.
Okay.
Yeah.
Tell us about immune checkpoints, inhibitors.
So you can look at the slide. So immune checkpoint inhibitors, basically this concept is very smart and very interesting how they came up with this. We know when there is a tumor in the body, it produces antigens or proteins. These proteins are taken up by cells which are known as antigen presenting cells or dendritic cells, which are present in all the organs of our body, almost all. And these then interact and they activate cells known as T cells, which are the immune cells. And these T cells go back and kill the tumor cells. So essentially, nature made us with a system where we can on our own kill the cancer cells. But what happens? Why does it stop working? So then we figured out there's a negative feedback, which will be seen in the next slide. So in the next slide, you'll see there's a negative feedback. What happens? So there is interaction between the cancer cell and the antigen presenting cell that blocks this pathway. So the tumor cell no longer is able to activate the antigen presenting cell. Then down the road, this T cell that is activated, that is determined to kill the cancer cell, also gets a negative feedback from the
tumor cells
and stops it kind of stops it from working. So that's how we figured out we could create antibodies that will target this negative feedback.
Right.
So that's
create
how we
some antibodies.
Yeah, that's how we came up with these antibodies that would stop these breaks from putting on the immune system. That's why they are known as checkpoint inhibitors, or pulling off the brakes from the immune system. So one of the antibodies that we use is ipilimumab, or CTLA4 antibody.
Okay.
So that is the one. That is the one that works initially when the tumor cell interacts with the antigen presenting cell. And at that time, you stop this interaction, this negative feedback, so tumor cell continuously activates the
this
activates the antigen presenting cell to activate the T cell.
Okay. But some of the tumors, if they are too malignant, then probably they won't respond to anything, right?
We have had a huge success in melanomas.
Okay.
Huge success in melanomas.
Yeah.
So ipilimumab is considered the standard of care right now. So we used to have these targeted agents, like we still use them, like vemurafenib, which are pills for melanoma. But the durability of the response is not great with those. You get an excellent response, then the disease is back. But with immune therapy, since your own body is fighting the cancer, so it gives a much durable and long-lasting response and longer remissions. So that's the advantage. And then you come up to the next one. This is the PD-1 and PD-L1s. So those are the antibodies that work on the other side of the pathway when the T cells are killing the cancer cells.
Okay.
So when you take the brakes off the immune system at that point,
then
the
other
T cells
works,
continuously keep on bombarding and killing the tumor cells. Excellent therapy. That is the paradigm-changing therapy right now in lung
cancer,
kidney, in melanomas, and now government is clinical trials are right now done on any advanced cancer, bladder, pancreas, any cancer. Basically, we are trying to use these PD-1 and PD-L1s to have
PD-1 and PD-L1 for
so
those.
There are two drugs right now, like pembrolizumab, and
I read about that. I see some of the patients who are on this medication.
This for instance, the pembrolizumab, we also call it Pembro. So this became famous because one of our former presidents, Jimmy Carter, was treated with this therapy. So kind of that's how the drug becomes famous too. So he's in remission. He's doing well with pembrolizumab. Similarly, we have nivolumab. So nivolumab is another exciting drug. This is PD-1. Programmed death 1, or the immune therapy checkpoint immune therapy we are talking about, and very successfully right now we are able to use in lung, we are able to use in other cancers including colon, and trials are going on in kidney and everything.
For the viewers to know, once they're on those, how often they visit you?
That's a good question. So when we talk about treating the cancer, we have chemotherapy, then we have targeted therapy. Now we are talking about immune therapy.
We have three things there.
So the most important concept when we talk about immune therapy is that our immune system, the patient's immune system, should be intact. It should not be immune compromised to the point that you're not producing the immune cells that will kill the cancer cells. So that's first thing. The second thing is they can work alone. You don't need any additional therapy because you are creating the immune cells in the body to kill the cancer cells.
Right. So just one therapy once they are on that.
Right. So it's like, for instance, nivolumab is given every 2 weeks or 3 weeks. Pembrolizumab is given every 3 weeks. But something very important that we are still exploring is once you take the brakes off the immune system,
then they
you
recur.
are also experiencing adverse effects,
Right,
which are
yeah.
very difficult sometimes.
A kind of adverse reaction after
Right.
you
So
stop.
it's a simple concept. So nature made checkpoints in the immune system. So what if you remove these checkpoints? So you create autoimmunity. So I can give you an example. I had a patient, a lung cancer patient, progressed on chemo, then some targeted agent, then put her on immune therapy. And she was in 50s and she was having excellent response. And cancer was almost undetectable in the body. PET scans were clean. But unfortunately, she develops inflammation of the pituitary gland.
Oh my God.
She develops pituitary of this inflammation of the lungs known as pneumonitis.
Oh.
She develops the inflammation of the bladder known as hemorrhagic cystitis. So I'm just
so
telling
those
you,
are the complications that are no good.
And we at this point are not able to control everything. And because when we give them immune suppression with steroids and other agents, the cancer therapy theoretically will stop working because you're suppressing the immune system.
Definitely, yeah, you are doing that. Do you put them on steroids also when they are going through like low dose of prednisone?
We sometimes give them steroids to avoid transfusion reactions, but essentially
Okay.
you don't want them immune suppressed.
No, because steroids again will suppress the immune response.
Right. But on the good side, I can give you example how successful this therapy can be. I had a patient last year, very nice lady in 60s with carcinoma of unknown origin, likely lung, likely breast, didn't know, cancer all over the body, including brain, and what we call as leptomeningeal disease or cancer in the tissue of the brain, in the fluid. So talked to the family, we told them the survival is, in the situation is 6 weeks. But we do have some things to offer. There are some trial medications. The company was good enough to give us on compassionate basis a drug known as pembrolizumab that we were talking about.
Right.
And it has good blood-brain penetration. It worked really well. And guess what? Instead of 6 weeks, she ended up surviving 1 year, 4 months.
Great.
1 year,
That's
4 months.
very good, yeah.
But then, then there are autoimmunities and then infections.
Complications, of
Yeah.
course.
She ended up dying, but from 6 weeks to 1 year, 4 months, I think that was a huge
So now,
benefit.
in the papers and everything, we read about this CART technology.
Right.
Can you highlight our viewers about that?
Right. So before going to the CAR technology, I would go back to some cancer vaccines.
Yeah.
So we are also in the era after immune checkpoints. We came up with the idea of why can't we have vaccines for cancers?
Yeah.
So there are two categories in vaccines. One is preventative. So right now we know there is a benefit of preventing cancers by giving vaccines, like you give hepatitis C vaccine,
Right,
you give hepatitis B vaccine, you have vaccines for HPV,
right,
human papilloma virus that prevents
so why
cancers.
not vaccine for prevent cancer?
And now after prevention, treatment. So we have vaccines that are under development right now that will be treatment for the cancers. There's one example that is currently we use is Sipuleucel T. Sipuleucel T is a method by which this is shown in this picture. So what we do is basically we get these T cells from the body of the person who has prostate cancer. So these are taken in the lab and they are engineered, they are trained to kill the prostate cancer. They are exposed to prostate antigens and grown in the lab. So now you are creating an army in the lab, which are T cells, which are immune system cells, and then you're putting these immune cells back into the person who has prostate cancer. So these cells go and start killing the prostate cancer because they're already trained. So you're getting a trained army, putting them into the patient who has prostate cancer.
But when you give those vaccines, that's just a small amount of that vaccine, right? Like any other?
Well, this is pretty expensive, and the downside is that they have to do it 2 to 3 times. So they come to the apheresis center known as where they donate blood. So this blood is then shipped to a center where they grow these cells in the lab and train them and expose them to the antigens. and then these cells are got back and infused back to the patient.
To the patient.
So this is one
It's
of
a
the
kind of
dendritic cell vaccine technology. Then we have oncolytic vaccines which are used in melanoma right now. Imlotec is one of those, and they are showing excellent responses. Then we have vector-based vaccines where the vector is used. Then we have antigen vaccines as well. So overall, we are having excellent responses with vaccines, but it's kind of still evolving and developing field.
Yeah, and also it must be really very, very expensive.
Very expensive.
Those vaccines.
Thousands and thousands of dollars.
But down the road, that will become a part of the routine immunization.
Yes.
FDA will approve that, right?
Correct.
Like pneumococcal vaccine, we didn't have it before. Now it has become.
For preventative,
HIV,
we have Gardasil already. We have HPV vaccines. For preventative hepatitis and HPV are there. But for treatment, it's going to be a challenge to get the costs down. It's not easy. They are pretty expensive therapies right now.
Yeah, that is true. Yeah. So now the we talked
immune
about
modulators,
the immune modulators for the prostate, linked to the prostate.
So immune modulators are basically agents that influence the immune system. For instance, we have a drug known as thalidomide and lenalidomide, which are used in myelomas. To be honest with you, don't know how they work. So the reason they were used it's a very interesting story. Dr. Barlogi is still alive. Very interesting story. One of the patient's spouse calls the doctor like, can we use this immune modulator? Doctor says, we don't know whether it will work or not. Guess what? Let's try. There's nothing else to offer to the patient anyways, let's do it.
Yeah.
So guess what? The patient has excellent response, and then Dr. Barlogi does a trial, and then lenalidomide, thalidomide are the standard of care for myeloma these days. They work so well, even in the toughest cases, these agents are the standard of care. Right, so these immune modulating agents, similarly we have imicoids that are used for peripheral, these warts and peripheral tumors and lymphomas. So this is also an evolving therapy.
So that's great. Now the last one, we are going to talk about the CART technique. Very interesting.
Yeah. So chimeric.
For the children and lymphomas.
Yeah. So this chimeric antigen receptor T-cell technology is very new technology. It's very new technology. This is something that is going to revolutionize the cancer care. So let me explain it on the next slide. So what we do is basically we all have these immune cells known as T cells.
Right.
So what we do in these T cells are taken out from, for instance, let's take a child who has ALL. And
acute lymphocytic
leukemia, very tough disease, doesn't respond to anything. So we get these T cells out of the body of that child and then genetically modify the antigens on the T cells in the laboratory, and then these cells are grown in the lab. So they have chimeric antigens, they have a lot of antigens, and once these T cells are grown in the lab, they are put back into that kid who has ALL or a person who has this aggressive leukemia. And then these T cells are trained, they go and kill the cancer cell. So far they did trial on like 5-6 patients and they are in complete remission.
The kids are in complete remission.
Yes, and now we don't know whether this is a cure or time
it
will
just
tell.
It just suppresses the cancer.
Right.
But who knows?
So the time
they might have killed all the cells.
Correct.
Right?
The time will tell whether this is a curative therapy or this is just treatment to put them into remission. But so far they presented this in the last meeting in American Society of Hematology in December. Excellent therapy.
Well, it's good to know about
it's going to change the paradigm of treatment
it should,
cancers.
because kids with a leukemia, especially lymphoid leukemia, so
right, aggressive treatments. You have something that's so easy.
So no more chemotherapy. Now. Stick to the
that's going to be our mantra.
Stick to the immunotherapy
of the new world.
Targeted
and immune therapies.
Targeted and immunotherapy, the new treatment for the malignancy of any kind, right?
Correct. Yes.
So that's good. I'm so happy you could come. And for our viewers to know, this is the second segment of the talk by Dr. Mohammad Muhsin Chisti, who is assistant professor at McLaurin and Karmana. I'd like to thank our viewers. I'd like to thank our photographer, our videos producer for helping me produce these shows. And have a wonderful spring and summer. Thank you.
Thank you very much. Please consider clinical trials.
Clinical
trials are very important. Thank you.
Oh,